Come on.
Your English is very good, Chico.
Uh, I think we're online now.
Okay,
So, okay, I'm gonna just give a little bit of information in Portuguese, and then I'll introduce yourself. All right, Mike?
sounds good.
Ok. So, boa tarde a todos, né? É uma satisfação poder dividir esse momento aqui com vocês, né? Então, nós fizemos de uma forma que, ao final, né, as perguntas podem ser colocadas no chat e, ao final, então, nós tentaremos apresentar todas as perguntas, se for possível, se não, algumas perguntas, e, de qualquer forma, o professor Collins fica à disposição por e-mail e eu posso fazer essa intermediação. Tá legal? Então, so now, Mike, I'm gonna change or switch to English mode. So good afternoon to you all, and thanks for attending to this webinar today. I believe this is a very special moment for this institution. With the support of the dental and medical schools, we have just recently created the group of rare diseases at São Leopoldo Mandic Research Center. And this group has worked hard trying to bring people together and identifying opportunities to collaboratively work with other research centers in an inclusive way. So today I would like to introduce Dr. Michael Collins. Mike is, with no doubt, one of the most important research in the field of bone biology. He is a senior investigator and chief of the skeletal disorders and mineral homeostasis section at the National Institute of Dental and Craniofacial Research at NIH in Bethesda. Mike is physician scientist trained in endocrinology and metabolism, whose research is broadly focused on the roles of PTH and FGF23 in bone biology and mineral homeostasis. Mike, we are very honored to have you presenting today to our group about your work on FGF23 related conditions. So thank you so much for accepting to share your insightful experience with us today. So it's all yours now. Thank you very much.
Thank you, Chico. That was a very kind introduction. I appreciate it. It's my pleasure to do this. I remember fondly your time with us here at the NIH, and I was sorry you had to leave, but I understand. Hopefully you'll be back with us soon. Anyway, so FGF23 has been one of the major focuses of my research for a long time, and I'm very glad to share this work with you. And the title, The Yin and the Yang of this, I say because I'll approach this through the lens of a clinician and through the lens of disorders of FGF23 excess and deficiency, which, as you'll see, really do reflect a sort of yin and yang of FGF23 and mineral homeostasis biology. So the way, first, disclosures. Yes, so the NIDCR received support from, it was NPS, and then it was Shire, and then it was Takeda for preclinical studies in familial tumoral calcinosis. And QED Therapeutics supported a study of infigratinib in tumor-induced osteomalacia that we did here at the NIH. And you'll see how these disorders come into play in a minute. Okay, so the approach I'll take today is to first review FGF23 and phosphate physiology and biology, just to make sure that we're all on the same page in terms of our understanding and background. Then I'll go into some of the disease-specific mechanisms, because it really has been, for me, the diseases that provide the first insights into understanding the biology and physiology of bone in these circumstances. And then I'll hit upon the clinical implications in the treatment of some of these disorders. Okay, first though, here is a little triptych, if you will, across the historical discovery of FGF23. And a good place to start, I think, in this sort of kind of modern era is with Fuller Albright, and this was this initial description of a patient with what he called vitamin D resistant rickets in 1937. And they knew this to be a different condition. It wasn't vitamin D resistance, there was something else going on. But for another 20 years till 1957, it wasn't clear what this was until it was discovered that these patients that you see here in a large family from North Carolina, that this was actually an X-linked condition. So they called it X-linked rickets. Fast forward a couple years to 1959, and this was really the first person, Andreas Prater, who's a pediatric endocrinologist in Switzerland, identified a girl who had a tumor on her rib that was associated with hypophosphatemia, and that when they removed this tumor, her hypophosphatemia went away. And he made the speculation that it was something made by this tumor. It was a giant cell granuloma, which was actually a case of tumor-induced osteomalacia, you'll see, that this tumor produced a rachitogenic substance, a hormone, in other words. So this was really the first insight. Again, fast forward 20 years, and they discovered a mouse that had the same X-linked phenotype as the patient's. A couple years later, they showed that this mouse, that if you hooked this mouse with the X-linked disease up to the wild type, that the X-linked mouse gave the wild type mouse hypophosphatemia and osteomalacia. And this then also supported the fact that this was something in the circulation, that this wasn't a defect in the kidneys, that this was a circulating substance, a hormone. 1995, the era of genetics, and we discovered that the genetics of this X-linked disorder is a mutation in an endopeptidase called FEX. This was interesting, it was important, didn't answer the question. Not really until the year 2000, Michael Ekons and others discovered that it was a fibroblast growth factor, an FGF23, that was the cause of this. Excess FGF23 caused this condition and a number of conditions. A few years later, again, the opposite condition, the yin and the yang, was discovered that deficiency of FGF23 causes this disorder of familial tumoral calcinosis. And here we are today, and there's been a lot that's been done in the last 17 years, and I'll bring you up to date with all of that in a moment. Okay. So these are the primary disorders of FGF23. And as you can see, I have these broken down to disorders of FGF23 excess, disorders of FGF23 deficiency, and then there's this little outlier here of renal failure, which I'll touch upon at the end briefly. But anyway, it's divided mostly among disorders of FGF23 excess and FGF23 deficiency. And this is how I'll frame the approach to discussing this today, is in terms of the disorders. So, first thing, though, is to review just some of the underlying physiology of this to make sure that we understand it. So, phosphate goes into the circulation, and in the kidney, it's all filtered at the glomerulus, and then it's reabsorbed along the tubule, and that which isn't reabsorbed goes out into the urine. Most of this is reabsorbed in the proximal tubule by a sodium phosphate cotransporter. And most of us, most of the time, reabsorb the vast majority of our phosphate, circulating phosphate. Only about 5 to 10% are excreted in the urine. Now, FGF23 is a potent regulator of phosphate reabsorption, such that high or higher levels of FGF23 inhibit phosphate reabsorption. They lower blood phosphate, with the result that there's an increase of phosphate in the urine. Now, parathyroid hormone does the same thing at the proximal renal tubule. It also inhibits phosphate reabsorption. So FGF23 and parathyroid hormone have similar actions here at the proximal tubule. And one of the clinical implications of this is that if you have hyperparathyroidism on top of a disorder of FGF23 like XLH, for example, it makes FGF23 excess even worse hypophosphatemia, even worse hyperphosphaturia. So FGF23 and PTH have overlying actions here at the proximal tubule. Now, the other very important role that the kidney serves in mineral homeostasis is that of the conversion of inactive 25-vitamin D through the enzyme 1-alpha hydroxylase to the potent active hormone of 125-vitamin D. So 125-vitamin D has its primary action at the gut, where it promotes the absorption of calcium, and to a lesser extent phosphate as well. So the result of 125D action is to increase blood calcium and phosphate. Now here, FGF23 is a potent inhibitor of 1-alpha hydroxylase, such that in states of FGF23 excess, you have low levels of 125D, less GI calcium absorption, less phosphate absorption, and lower blood calcium and phosphate. The clinical implication of this is that you have, in states of FGF23 deficiency, elevations in blood calcium and an elevation in the calcium phosphate product, which is one of the major problems you'll see later when we talk about familial tumoral calcinosis. So FGF23 action. So this slide here covers years of research to give us a summary of how FGF23 carries out its physiologic function. So we and others showed that FGF23 is made primarily by bone cells. So bone cells make FGF23, they release it into the circulation. It has its primary action at proximal renal tubule cells. It does this through binding to the FGFR1 receptor. It requires a co-receptor that has a very limited tissue expression, Klotho. And through this co-expression of action of FGF23 binding to Klotho and FGFR1, it acts, as I said before, with the sodium phosphate cotransporter and 1-alpha hydroxylase, with the effect of lowering serum phosphate and lowering serum 125D. Okay, so now how is FGF23 regulated? Well, this is a complex and evolving story. But as you would predict, if FGF23 regulates phosphate, 125D, calcium, and phosphate, that these also will regulate FGF23. So we have, in this case, a sort of endocrine feedback loop, that phosphate and 125D regulate FGF23, FGF23 in turn regulates their blood levels. And again, there's been a lot of research over the years that have led to our understanding as it exists. Interestingly, though, there's a new and evolving area that shows that hypoxia-inducible factor, erythropoietin, and iron, so this HIF-EPO-iron axis, also plays a role in regulating FGF23. And we'll hear a little bit about this later in terms of autosomal dominant hypophosphatemic rickets. But this is a very interesting and evolving area that's going on right now. Okay, I want to say something first about FGF23 assays, because this can sometimes be a point of confusion. So the most common commercially available assay right now is this assay that's called the C-terminal assay. And it's called the C-terminal assay because both of the antibodies that are used to detect the FGF23, the capture antibody and the signal antibody, are both directed against epitopes in the C-terminal of the protein. That said, while, yes, it detects C-terminal FGF23, it also detects the intact molecule as well. So this can sometimes be a source of confusion because there are diseases, as you'll see, where there are differences between the ratio of intact to C-terminal FGF23. Now, becoming available more commonly are assays that detect only intact FGF23. These, in most cases, are better. Sometimes these two assays can complement each other. But we're looking forward to the day when these intact assays become the ones that are uniformly available. And you can see they have the capture antibody and the signal antibody, one on the C-terminal and one on the amino terminal. So that's all about FGF23 assays for right now. Okay, this really gives you a sense of the differences of the yin and the yang of disorders of FGF23 excess and FGF23 deficiency. And so this is sort of a typical FGF23 excess disorder. This happens to be tumor-induced osteomalacia. But what you'll see is that the dominant driving feature, this is low blood phosphate. This is caused by impaired reabsorption of phosphate at the kidney. The TRP measures the reabsorption of phosphate at the kidney. FGF23 levels are quite high, so that's what drives these two things here. As I said before, the 125D levels are either frankly low or inappropriately low. In states of phosphate deficiency, 125D levels should be high. The parathyroid hormone levels are generally normal, but a physiologic response to the low 125D is to develop secondary hyperparathyroidism, and the blood calcium is normal. So this is in contradistinction to FGF23 deficiency. And again, this is patients with familial tumoral calcinosis. They have very low to undetectable levels of intact FGF23, very high levels of C-terminal FGF23, but this C-terminal FGF23 is inactive. It doesn't have any biological effect as far as we know. The blood phosphate levels are quite high. The blood calcium levels are either high normal or frankly high, and that gives us a high calcium phosphate product. And it's believed that this high calcium phosphate product leads to the ectopic calcification, which I'll show you in a few minutes, that's present in this disorder, and is really one of the most pronounced parts of the pathophysiology. 125D levels here tend to be high normal, and PTH levels here tend to be low normal. So this really gives you a picture of the FGF23 excess, FGF23 deficiency, the yin and the yang. I did want to go through briefly for the clinicians and for myself the evaluation of hypophosphatemia, because this is important, because not all cases of hypophosphatemia are caused by FGF23 excess. And before you consider this, you really have to rule out these over here. So the way you approach this, patient comes in with low blood phosphate. First of all, you make sure that the low blood phosphate is due to renal phosphate wasting and measure TRP. Many sites on the web will tell you how to do this. And then it becomes to consider whether this is a primary renal defect or the kidney's working fine, but this is too much FGF23. So the thing you do is you check plasma FGF23. And if FGF23 is low, then you have to consider these disorders, these primary renal disorders. And these are Fanconi type tubulopathies, where there's dysfunction in the proximal tubules. There's amino aciduria, proteinuria, bicarbonaturia, calciuria, in any combination. There's genetic, and there's also acquired. The acquired forms can be caused by toxins, lead, calcium, things like that. And then certain drugs can do this as well. And I underline tenofovir here because tenofovir is getting used more and more, especially in prevention of acquisition of HIV, for example. And about 20% of these patients who are on long-term tenofovir develop a renal tubulopathy with either frank or relatively low blood phosphate levels, which have long-term effects on skeletal integrity. So I think this is important to think about in our patients on chronic tenofovir. Then that brings us to the disorders of FGF23. The color coding here is along the color coding of the table that I showed you earlier. And I'll go through these here sort of one at a time. The one I won't talk about, though, is this one here, metastatic cancer. So you can see rarely high levels of FGF23 and hypophosphatemia in certain advanced cancers, especially prostate cancer. Mechanism of this isn't clear. It's usually never tricky what the cause is. These are patients with very advanced cancer who happen to have seen in association hypophosphatemia. The treatment for that, of course, would be to treat the underlying cancer, but at this stage, that's often not possible. So the treatment is usually the same as for other disorders of FGF23, which I'll go over in just a minute. Okay, I wanted to go through some of the findings in some of these disorders, XLH, for example, which is usually almost always picked up in childhood, although not always. And of course, it's a genetic disease, and the difficulties continue into adulthood. So you see malformation of the growth plate. The growth plate is not ossified. The growth plate is widened, and the wrist will have these findings shown here. You get bowing of the long legs. This is a major problem. And in adults with XLH, they get these fractures along the compression side of these osteomyelitic bones. Because of the associated, sometimes profound secondary and even tertiary hyperparathyroidism in XLH, these patients also can develop these brown tumors within bone, which I won't go into, but these can be quite concerning when you see them because it really can look like cancer, but these are brown tumors, and if you're able to control the hyperparathyroidism in these patients, you can treat those brown tumors. Anyway, so that's some of the findings in XLH. So, how does this happen? Well, I showed you earlier that XLH is caused by mutations in this enzyme that we called FEX that has this very long name. And we didn't know for years how this FEX worked. In fact, the discovery of the enzyme was made, and we thought we had it all figured out. But it really was not yielding for quite some time. We have made some progress. We know that involved in this is this FEX actually acts upon this family of proteins called siblings, small integrin binding ligand in-linked glycoproteins, this group of proteins. So somehow this endopeptidase acts on this family of proteins, and somehow, we still don't know yet, and these are bone-expressed proteins. They're quite prominently expressed in bone in the extracellular matrix. And somehow this leads to FGF23 excess. So this is an interesting area of active investigation at this time. I wanted to speak just briefly about this very rare condition that we now call ENPP1 deficiency syndrome. And it's due to deficiencies in this enzyme ENPP1. ENPP1 is another mouthful, shown right here, the full name of it. But the really important thing, and the reason I wanted to mention this and make note of this, is that ENPP1 is an enzyme, again, extracellularly membrane-bound enzyme that is involved in the formation of pyrophosphate, PPI. Pyrophosphate, it ends up, is an extremely important regulator of calcification. And in fact, it's because we have relatively high levels of PPI in our circulation that we don't regularly calcify our blood vessels, that we don't regularly calcify our muscles when we have trauma to them. So PPI, pyrophosphate, is really important, underappreciated, I think. And so mutations in this very rare disease of ENPP1 deficiency cause low levels of pyrophosphate, and you could predict low levels of pyrophosphate then lead to calcification of the artery. I don't know if this projects so well, but the large vessels in this child are heavily calcified. The condition is still often called generalized arterial calcification of infancy. This is a venogram, and you can see that these large vessels are occluded. These children often die in infancy due to calcification of the coronary arteries. So this is a really terrible disease. What's also very interesting about this condition, and again, this is something we have almost no handle on, is for those infants who make it through infancy and survive, they always develop FGF23 excess. Perhaps this is protective in these patients, but again, the mechanism of this is almost completely unknown. Fortunately, though, there is hope for these children coming along. There's replacement therapy with an ENPP1 replacement protein. Trials of this should be starting soon. It's a company called Inozyme that's doing this work. So this is another one of these rare diseases where there's been great progress in the therapeutic end, as you'll see with others I'll talk about in a moment. I'm not going to talk about these, but just to mention that there are also mosaic disorders of FGF23 excess. One that we have done a lot of work in is McCune-Albright syndrome, shown here on the left. It has, as part of its pathophysiology, rickets, osteomalacia, but it also has a lot of extracellular, extraskeletal manifestations as well. But FGF23 excess can be a common feature of this, again, like in so many disorders of FGF23 excess. The treatment of it is the same, which I'll go over in a minute. Same here, this is an even rarer condition, cutaneous skeletal hypophosphatemia. These patients can have rickets and osteomalacia, and this is caused by gain-of-function mutations in RAS. Here again, the mechanism of how gain-of-function mutations in RAS bring about this disease, not clear. So a lot of areas of very active research going on right now. This is another disorder of FGF23 excess. This is probably one of the most profound disorders of FGF23 excess. This is an acquired condition, presents usually in adulthood, and there are these teeny little tumors, often very difficult to find, that make very high levels of FGF23. These patients can have profound hypophosphatemia, renal phosphate wasting. They can develop a very severe skeletal phenotype if you can't find these tumors and remove them. Good part is that imaging modalities like gallium-68 DOTA PET-CT are pretty good at finding these tumors. It's very satisfying. You find the tumor, you excise the tumor, the patient's cured. It's very satisfying as a clinician. The pathophysiology of this has been yielding and recognized recently, and that's shown here. It's been shown that probably about half of these phosphaturic mesenchymal tumors harbor these fibronectin-1 FGFR1 translocations. So this makes a chimeric protein that has the extracellular domain of fibronectin-1, the ligand-binding transmembrane and signaling domains of FGFR1. And exactly how this works, we're not clear. This could be through autodimerization, which could bring about signaling. It could be through clotho-independent FGF23 binding. It could be through clotho-dependent binding. Not sure about this. But either way, these translocations, this chimeric protein, result in high levels of FGF23 and tumor-induced osteomalacia. And I'll show you in just a couple slides here how this has led to a potential therapy, a new therapy for these patients as well. Okay, so just briefly how to approach tumor-induced osteomalacia, because this is a good opportunity to go over this. So you have a patient, they shows up, they have hypophosphatemia, you think it's tumor-induced osteomalacia, carry about functional imaging, which I talked about, those gallium-68 or Octrio scans, anatomical imaging to confirm that there's a little teeny tumor there. You identify the tumor. If it's a single lesion, wide excision, make sure you get all the margins of this and you're cured. Again, very satisfying. However, sometimes there's multiple lesions. Not all of these imaging modalities are terribly specific. And this is a case where you can do venous sampling. So you put a catheter in the venous tree near the tumor. And if the FGF23 levels are high near the tumor, it's the tumor, wide excision, cure. Not always possible. If the tumor is unresectable, either because of its location or the patient can't tolerate tumor, there are ways to get rid of these tumors by catheter ablation or radiofrequency ablation, other ways such as that. But sometimes, in about 20-30% of these patients, you can't identify the tumor or you can't take the patient to the operating room. And in this case, these patients are treated with medical therapy. So the traditional medical therapy is phosphate and 125D replacement, as we talked about. This is a very difficult regimen. You have to give a lot of phosphate. You have to give it 3 to 6 times a day. It almost always causes GI upset. A lot of patients can't tolerate it. And the goal of this, when you give phosphate replacement, is to target mineralization. So you're not necessarily really trying to raise the blood phosphate level up to the middle of the normal range, because it's not possible. So you need to also control for the secondary hyperparathyroidism, which I talked about, which arises in this condition. And for that, you need to give these patients calcitriol, which I'll show you here. But again, as I said earlier, the final common pathway of treatment for most of these disorders is the same. So that's the good part, that these different disorders can be treated the same way. As I said, you have to add calcitriol 125D. You can either do this in the form of calcitriol or alpha calcidiol, depending what's available. Relatively high doses, this improves GI calcium absorption and phosphate absorption. It prevents the secondary hyperparathyroidism, but you have to be careful because if you give too much, it can cause hypercalciuria. So you also have to monitor the 24-hour calcium, 24-hour urine calcium. And again, the target of this is to keep the PTH within the normal range. I add this cinacalcet, which is a drug that lowers PTH levels. It's a agonist of the calcium sensing receptor. Can also be an adjuvant to treatment. So if you're doing everything else and it's not working and you don't have furosemide, which I'll talk about, you can add cinacalcet. And this can help to control the therapy. But you have to be careful. It can worsen the hypercalciuria. So the big breakthrough in this area in the last 5 years or so has been this drug furosemide, called Crysvita, as medical therapy. It's a monoclonal antibody against FGF23, so it blocks FGF23 from interacting with its FGFR1 and Klotho receptor. In the U.S., it's approved for the treatment of XLH and tumor-induced osteomalacia. But in fact, this is also used off-label to treat basically any FGF23 excess condition. So it's a really very effective drug. So far, it seems to be very safe as well. It is, like many of these new drugs for rare diseases, expensive. So it's about $200K US dollars per year for treatment. So expensive drug, but works well. Okay, and this is infigratinib. This is what I was telling you about with tumor-induced osteomalacia. So this is will target those tumors and block FGFR1 signaling. So it's a specific pan-FGF receptor inhibitor. It blocks FGF23 signaling. So in some cases of tumor-induced osteomalacia where everything else has failed, and especially in those patients who can develop metastatic disease, which really can be an impossible condition to treat, infigratinib will work, and that's shown here. This was a patient who we saw who had metastatic tumor-induced osteomalacia. Very high levels of FGF23, started on infigratinib, and FGF23 levels just plummeted. Phosphate levels normalized, and as you can see, he showed up with pretty widely metastatic disease, went on infigratinib, all his tumors melted away. Very difficult drug to tolerate, though. It's a tyrosine kinase inhibitor. It has many of the side effects of tyrosine kinase inhibitors. This patient eventually just could not tolerate it. Went off the drug. His FGF23 levels went crazy. His disease took off again, restarted the drug, and again, tumors melted away. But eventually, this patient succumbed. But he did get 5 years of pretty good quality of life out of this with use of this infigratinib. So great drug. Difficult to tolerate, a lot of side effects, but in the right patient, really good drug. All right, this is a very interesting disease, autosomal dominant hypophosphatemic rickets. So this is studied by Eric Immel and others at Indiana University, and they made the very astute finding that patients with ADHR1 really only get hypophosphatemic, really only get increases in their FGF23 levels when they're anemic. Normal patients, control patients who, when they become anemic, you and I, we don't get changes in our levels of intact FGF23. So this suggested to them that somehow iron, HIF, EPO are playing a role in FGF23 regulation. And that it's playing a role in FGF23 regulation by affecting the processing of intact FGF23 to C-terminal FGF23. And that's shown here because normal patients, control patients, when they become anemic, they have normal levels of intact FGF23, but they have increases in their C-terminal levels of FGF23. And I'll show you in a minute then how this really points to the fact that post-translational modification of FGF23 is an important process, and it's a regulated process, and it will provide insight into how FGF23 is regulated. What this also showed, though, very interestingly, then, that is quite simply, iron replacement is a valid treatment and works with people with ADHR1. This was the study recently by Eric Immel and JBMR showing patients with autosomal dominant hypophosphatemic rickets, iron replacement controls their disorder. But importantly, as I said, low iron leads to increases in the hypoxia-inducible factor EPO pathway. This goes to increase FGF23 transcription and translation, but also into increases in post-translational modification if you don't have this ADHR1 mutation. So I just wanted to briefly talk about this post-translational modification of FGF23. It's very interesting. Ends up, there's an enzyme, GallanT3, which it too has a very long name that you'll see here. And GallanT3 is involved in glycosylation. So it glycosylates FGF23 at a number of sites. And once glycosylated, FGF23, intact FGF23, is secreted from to the cell and has its action. Now, you can, So this is what happens if there's a defect in glycosylation. If for any reason FGF23 is not glycosylated, it gets broken down into the C-terminal and N-terminal parts of FGF23, and you lose the phosphogenic effect of FGF23. I showed you earlier that FGF23 is regulated by phosphate 125D, calcium, some of these other gain-of-function mutations in RAS, etc. effects I showed you. Now this, what I showed you just a moment ago, brings into highlight, though, that there's a novel level of regulation of FGF23 at the post-translational part of the pathway. And this is carried out about iron, HIF, and EPO. And support for this, I think, was shown here. And this was this paper that we recently published where we saw a group of patients at the NIH had a very rare condition, paragangliomas, due to gain-of-function mutations in HIF2 alpha. So they had high levels of HIF2 activity, high levels of EPO, polycythemia. Interestingly, though, they had normal levels of intact FGF23, but consistent with regulation of post-translational modification. They had very high levels of FGF23 that correlated with the degree of erythropoietin. And so the post-translational regulation was able to keep these patients normophosphatemic. So increase HIF activity, increase EPO, increase FGF23 transcription translation, but the post-translational regulation is able to maintain euphosphatemia in these patients. So you can lose this post-translational regulation in a number of ways. The most common way are mutations in GallanT3. Less common are mutations in FGF23 itself. Even less common are mutations in Klotho. There's only been one case of this reported. There's been one case of FGFR1 mutations reported. And we've had one case of autoimmune FGF23, so antibodies to FGF23. Either way, any of these can lead to the condition of familial tumoral calcinosis. This is a really fascinating disorder, and I have some features of the phenotype shown here. So these patients get ectopic calcification, these subcutaneous ectopic calcifications here, ectopic calcifications here, sometimes massive ectopic calcifications with liquid calcium hydroxyapatite, as shown here. It's associated also with inflammation, so it appears that these particles of hydroxyapatite trigger a massive inflammatory response sometimes, which can have its own secondary effects. Ectopic vascular calcification as well. So a really interesting disorder. A lot of questions remain here as well. So why does calcification occur? Where it occurs? Why here, here, here? Not clear. What's the role of inflammation? Is it a secondary effect, or is it a primary effect, the inflammation? And is it truly FGF23 deficiency, or is it tissue deficiency of gallon T3 as well? So a lot of these questions open to investigation right now. In the cohort that we've seen here that we most recently published, which is a cohort of 17 patients, 92% of these patients have dental calcification. This actually is the most penetrant part of the phenotype. So this disorder can be picked up in the dental chair in childhood. These pulp stones that are present in HFTC, these misshaped tooth roots are present very early and the most common feature and often the presenting feature if there's an astute dentist seeing the patient. In our cohort, most of the patients have ectopic calcification of varying degrees. And interestingly, we didn't really appreciate this at first, is a lot of these patients get vascular calcification. This happens later, but it really can be quite profound and something to be aware of. Again, this is the cohort here, and I showed you dental vascular soft tissue calcification, the relative prevalence shown here. The unifying feature in most of these patients is hyperphosphatemia, so this is what they have walking through the door. And again, a lot of these patients have a very striking degree, a lot but not all, striking degree of inflammation as shown by CRP here. And some of these levels of CRP here are really astronomical. These patients have a lot of inflammation. As you can see here over in the treatment column though, treatment is really a problem. We have tried a lot of things and there's no consistent response to this treatment. Interestingly, in fact, some of these patients without any treatment will wax and wane on their own. So I'm not sure that if any of the so-called benefits we've seen have been from our treatments or if this is just the natural history of the disease. So I did want to point out this one novel form of tumoral calcinosis that we recently published. This is a 7-year-old boy who came in, looked for all the world like he had familial tumoral calcinosis. He had high phosphate, high calcium phosphate product, looked like XLH, but he didn't have any of the mutations that are expected to be associated with this. And in fact, what he had was really some state of FGF23 resistance because he had elevations in both intact and C-terminal FGF23. So it was some form of FGF23 resistance. It eventually became clear to us when, while we were under observation, he developed type 1 diabetes, and we looked to see if he had autoantibodies against FGF23. And sure enough, he did. He had autoantibodies against FGF23, and his plasma with these autoantibodies was able to block FGF23 signaling, consistent with the fact that this was truly physiologic. Again, a little bit more about treatment. We've tried all these things. This is a patient who we tried everything in, and nothing worked in this poor guy. This was a little girl, a couple little girls who we treated. We treated this patient with a inhibitor of phosphate absorption, sevelamer, acetazolamide, and probenecid, which will both promote phosphate excretion in the kidney. And in fact, her calcification resolved. This was a little girl who showed up with a really marked degree of inflammation. This area on her neck was hot, it was red, her CRP was really high. We treated her with an IL-1 beta antagonist, canakinumab, and she had very dramatic resolution of this calcification. So this points to the fact that inflammation itself has a participatory role, if not driver role, in this disorder. So we're making progress in treating these patients. So what's next for HFTC? Well, sure enough, I mean, one thing that could be done was just FGF23 replacement. This is something that's under investigation. The other thing, if you recall, that the way that this works is that the sodium phosphate cotransporter in the proximal tubule, you could imagine that inhibitors of sodium phosphate cotransporter could be a treatment. And in fact, that does appear to be the case. This was done in vitro and in animal models of FGF23. And this Pfizer NaPi2a inhibitor showed promise that this could be a treatment. So again, there's hope for these patients that we'll have something better to treat them in the near future. Okay, so the one last thing I wanted to touch upon is this renal failure, which has very high levels of FGF23. And what's the role of this high FGF23 in renal failure? Well, the prevailing evidence right now is that high levels of FGF23 make this worse. They seem to be an independent risk factor for early mortality, especially through cardiovascular mortality and rolling heart failure. And as you can see here, that in patients who develop renal failure, as the renal failure gets worse and they lose renal function, actually the very first metabolic change that you'll see is an elevation in FGF23. So FGF23 goes up very early in an effort, a futile effort, eventually, to maintain euphosphatemia. Next thing that happens is the 125D levels go down as FGF23 goes up. Parathyroid hormone levels go up as 125D levels go down. And eventually, when all this fails, blood phosphate goes up. So this is really the hyperphosphatemia of renal failure is actually the last thing that you see in this condition. So FGF23 effects in renal failure increase mortality, cardiovascular. FGF23 goes up as renal failure goes up. There's some evidence that glycerol 3-phosphate is involved in this. And there is evidence from other disorders of FGF23 deficiency that if there were a way to control this FGF23 excess earlier in the condition, you might be able to prolong the effects of high FGF23 direct effects on patients with renal failure as well. So FGF23 blockade might be a possibility, although this failed in preclinical models. Phosphate binders seem to be effective, cevimeline, etc. And there's some evidence that NaPi2A inhibitors might be helpful in renal failure as well. Anyway, so that was the last disorder I wanted to talk about. And with that, I will close and thank the people in my group who I work with. This was from an earlier time, as you can tell. So now it looks more like this all day, every day, which I think we're all getting tired of and which we're doing right now. But anyway, it won't be like this forever. Anyway, with that, I will close and take any questions if you have any. Thank you.
Okay, that was very, very insightful. Thank you so much, Mike, for your talk and very impressive photos of this very special patient. So thank you very much. So there are a bunch of questions coming up, and I'm gonna just to pick a few of them and to kind of keep on time. So there's a very interesting question in terms of asking you to tell a little bit more about how the patient enrollment process works at NIH, because they might eventually, have patients coming up here that they might, be referred to you there in case you are not able to close the diagnostic.
Yeah, no, that would be great. And we welcome patients at the NIH from all over the world. We commonly see patients from South America here. It's in normal times, it's a simple process. You contact me, you say, I've got this patient, you show me the data. I say, yeah, that's you've got it. And in most cases, many cases, we can even pay for the patient to come here. We can bring a relative with them. We can house them while they're here. All of their care here at the NIH would be free. And this is great because this is how we build these cohorts. And you really need numbers to learn these diseases better. But right now, we're still, sadly to say, in pandemic mode. Our ability to travel people is limited. Our ability, our team is functioning at, I don't know, sort of half pace now. So super frustrating, but we would welcome any of these patients. And as you know, when you were here, Chico, you saw these patients here in the clinic, and that's how we learn when we partner with people from all over the world. So great question. Eventually the doors will be open again, and would love to see your patients with you.
All right. So another question that I thought was very nice was, there's this MD here asking, what's your experience taking part of any therapy development? If you had that opportunity to take part of a team developing a new drug, or how is it like there?
Yeah, so that's a really good question. So we welcome that, and that's been really a major focus of my work for the last decade. It's been fantastic that now these pharmaceutical companies, especially these small startup pharmaceutical companies, are interested in this. In fact, there's 3 pharmaceutical companies who are potentially interested in the treatment of familial tumoral calcinosis. So that's amazing. That would have never happened before. So yes, we engage in what we call public-private partnerships with these companies to treat patients here. We will often do, a proof of principle, small proof of principle trial here, and this will then expand into multi-center trials that can involve, because these rare diseases, you need patients from all over the world. So Europe, South America. So yeah, this is really been a fantastic, very satisfying breakthrough in my career to see that, there's now some therapies to offer some of these patients. The most satisfying of which was a different disorder, but autosomal dominant hypocalcemia type 1, a form of hypoparathyroidism. We have a very successful phase 2 trial going on right now with a small pharmaceutical company that's going to expand into a multi-center international trial that looks very promising. So, I've kind of been waiting my whole career for this, and now it's really happening. So it's incredibly satisfying to do this sort of work.
Yeah, it's fantastic. So there's we still have 2 more minutes, and I'd like to ask you one last question that I think is it's quite opportune, which is, how do you see? So here in Brazil, most of the patients are diagnosed clinically, and they barely have the opportunity to go for a genotyping or something like that. So how does it work there in the US? I mean, are the patients uh, um, um, do they have access for a genetic diagnostic, or they are most of them under the clinical phenotype basis?
No, so obviously the genotype is really important, and sometimes it will give you the answer, and sometimes it will help you sort it out, and sometimes there'll be a genotype phenotype correlation. But really, most of the time, this is a clinical diagnosis. A good, astute clinician, if you expect it and you order the appropriate laboratory tests and imaging tests, you make the diagnosis on clinical grounds. I'm a clinician by training. I very firmly believe in that. Blindly ordering a bunch of genetic tests can sometimes be very confusing. So I'm a firm believer in good, solid clinical diagnosis, history, physical labs, imaging studies, and that will get the answer most of the time. And in fact, most of the time nowadays, we don't have any genetically specific therapies. A few exceptions, I showed some. So it is important, not always important. The most important thing is good clinical evaluation.
Okay, sounds great. So, and perhaps one more question, if it's okay with you.
Yes.
I just got the bell here for me, but so the one thing that I would like to hear your opinion about is whether you believe that, for example, cementosides are FGF23 producers. So, in theory, so how you see that? Do you think that it's an important part of the process, or it's just locally, important? How you see that?
Well, that's a really good question, and I'm not surprised that you asked that question. But so what I'm pretty sure of is that it's important locally, because we see this very profound dental phenotype that's not really explained by systemic factors. And as you know, it is expressed by these cells in this tissue. So my guess is that it is playing a role. Now, does that contribute to the systemic regulation? Probably not. I think if you count the number of cementocytes and you count the amount of FGF23 that they could make, and you throw that over the blood volume of distribution, and my guess is it's not playing a systemic role, it's playing a local role. And like I said, we really don't have a good handle at what is involved in the tissue level dysfunction that takes place in HFTC. And I suspect it's absence of local tissue Gallin T3 in this case. But anyway, so there's definitely systemic and tissue specific levels of regulation. And in this case, the cementoblast, I think it probably is the tissue level regulation.
Okay,
but it's a guess.
Yeah. It's always something that intrigues us as a periodontist, as you know, and we had a number of opportunities to go over that while I was there. So Mike, thank you so much. It was great seeing you again after all these years, and to see that you are still in a good shape and a brilliant researcher. So thank you so much for your time and for the opportunity to have you with us today.
Thank you, Chico. Pleasure is mine. I look forward to seeing you back here soon. Take care.
Take care. Thank you very much.
Bye-bye.